Hello and welcome to this episode of the Triage Method podcast with me, Gary McGowan, and this week, Mr. Richie Kirwan. You're not quite at the Dr. Richie Kirwan yet, but you're almost there, I believe.
Give me a couple of months.
Couple of months. We'll have to get you back on for the first introduction, the doctor title. So Richie's been on the podcast before. You guys have listened to him talk about multiple different topics before. But what we want to do today is talk about something that we touched on in the last episode, and that was the topic of cardiac rehab. Because what we talked about in the last episode, if you haven't listened, was primary prevention of cardiovascular disease and the role that exercise in particular plays in the prevention of cardiovascular disease and thus the promotion of longevity and quality of life long term. And Richie has particular interest in this topic, you might say. He's certainly put in a lot of work over the last few years, probably longer than he'd like, into this topic. So Richie, you've been on the podcast before. We don't need a big introduction or story of your life, but what I'd love to get from you is some insight into how you became interested in this topic and some of the details of your research, maybe.
Yeah, sure. Thanks for having me on again. So when I started my PhD, the whole thing that interested me about my PhD was that we wanted to look at the effect of diet and exercise, and specifically Mediterranean diets and Mediterranean high protein diets and resistance exercise on cardiometabolic risk markers. And the population that we were going to work in, and this was already pre-decided before I started my PhD, was cardiac rehab. And the reason for that is just because one of my supervisors is very, very much involved in cardiac rehab here in the UK. And so I got involved in it through that. Beforehand, I had really no knowledge of cardiac rehab at all. And I would say that the vast majority of people, unless they have had some sort of a heart condition themselves, or they know somebody who has, will probably not even know it exists. And it's a bit of a shame because it's an incredible service when it's provided and when it's provided adequately, and we'll probably get into that. That can really, really help to reduce somebody's risk of having a heart condition or let's say a cardiac event in the future. And just for anybody who's not aware of what cardiac rehab actually is. So if somebody has a cardiac event, and that can take on a lot of kind of different definitions. If somebody's had a cardiac event, or if somebody technically is at high risk of a cardiac event, they will be referred to cardiac rehabilitation. And it's a service that provides education around a lot of different aspects of lifestyle. So for example, there's supposed to be educational components that talk about things like weight management, healthy eating, smoking cessation, and the big component of cardiac rehabilitation is exercise, and that's the actual component that they teach people about. So they bring people into classes which can be based in a hospital, they might be based in local community centers or gyms, and the whole idea is to help improve various aspects of cardiac function over a very, very limited amount of time, but hopefully to prepare people for going into this a little bit long term, so exercise becomes more of a habit for them. So that's kind of it in a nutshell.
Yeah, and I think it is interesting that exercise forms such a core part, because I think sometimes if you were to, especially if you were to go back 20, 30 years and you were to, ask someone on the street, should someone exercise after having a heart attack, or if they have heart disease, most people are probably lean towards no, because they'd be worried. They think that if I exercise, my heart rate's going to increase. You can actually feel that yourself. Someone might feel palpitations and they think, well, that's putting stress on the heart, which is true. And that's then dangerous. But as we talk about so often, that's, if you view the human body as a system that I guess can't repair, can't heal, and can't adapt, then fair enough, you've got a broken system, you don't want to stress it, but that's not really the way human physiology works, thankfully. So from the outset, I suppose, one of the things to note here is that when we talk about cardiac rehab, and you can expand on this if you'd like, Richie, it's not just, right, you've had an event, here's an exercise class, off you go. There's multiple different phases of that, and levels of intervention. And as you say, the education, exercise, and other components like smoking cessation, diet, etc. But there's a graded component to that. It's not like someone just has the event and then starts lifting 5x5 at 80% 1RM. There's clearly a graded component there and an assessment of tolerance, etc. So what do those different phases look like broadly if someone was to have an event?
Okay, so there in classic cardiac rehab, and there's talks about changing this at the moment. There are 4 phases. So phase 1 and 2, I genuinely myself, I don't know the difference between the two. They seem to meld into each other. So phase 1 and 2 is basically identification of somebody who needs to go into cardiac rehab. So you've had a heart attack. All of your details are taken. They'll be sent on to the cardiac rehab clinic with an assessment of what's gone wrong. And basically you'll be put in the pipeline to get referred to a cardiac rehab clinic. Somebody will talk to you about it. And then once you are deemed as being ready, whatever that may be, so that there's multiple components of that, you go to your cardiac rehab class. And this can take, like, between the time of actually having an event and starting your first cardiac rehab class, this can be a couple of months for some people. It's not something that happens straight away. And like you said, there is a leftover component of fear for individuals who had a cardiac event, and that continues to this day. Obviously, people are much more aware of the benefits of cardiac rehab within the medical profession, but there's still a little bit of carryover, and we can talk about that when it comes to resistance exercise, which is the kind of area that I look at, and kind of some of the pushback against that at the moment. But then people get referred to their cardiac rehab phase 3, and cardiac rehab phase 3 is where everything actually happens. And the thing with cardiac rehab is that it varies hugely between each cardiac rehab center. So if we talk about here in Liverpool, where I'm based, there are multiple areas. There are multiple large hospitals around the city. Each hospital will deal with a different cardiac rehab center. And by center, I mean not necessarily an individual place. One center may have multiple locations around, but they have a different cardiac rehab team. And all of those individual teams will have different ways of carrying out cardiac rehab. And I kind of found this out when I was doing the initial research for my PhD, because we wanted to find a cardiac rehab group center that we could work with. And we wanted to find ones that had, like, let's say, all of the best conditions that we thought were best conditions, in our opinion, to carry out our research. So, for example, we found that some cardiac rehab centers, their phase 3 cardiac rehab, which is the clinical phase. So these people are still patients, and they're still considered to be, heart disease patients. They haven't been fully discharged yet. Their cardiac rehab might last only 4 weeks. Other centers might do 6 weeks. Other centers might do 8 weeks. And in general, you'll find that the majority of cardiac rehab centers will operate a program of phase 3 between 4 and 8 weeks of length. And during that time, it's an introduction to exercise for most people. So people will come to cardiac rehab sessions. Again, how many during the week can vary greatly. For some places, it's 1 session a week. For some places, it's 2. You don't get a huge amount offering 3 or more, but it can depend on the place that you go to. And people will go, they'll have, if it's their first session, they'll have an exercise tolerance test, just to see how they're doing. There's usually going to be nurses present. There are going to be exercise physiologists present that are specifically trained in cardiac rehab. They'll have initial checks on blood pressure. They'll have blood pressure checks continuously. They'll have one at the start of their session. They'll have one at the end of their session. They'll have an exercise stress test, and then they'll be told what exercises then that they can do. And then there's usually a group exercise component. And the first time I saw a cardiac rehab exercise session, and for anybody who's listening, I'm doing air quotes here. It can look, again for the viewers or the listeners of this podcast, people who are used to exercising, quite intensely, it can look almost. I'm trying to find a nice adjective here. It can look quite weak in terms of dosage of exercise, because you will see older people who are just maybe walking around in circles, swinging their arms. And that's because for these individuals, this is kind of as intense as the exercise physiologists would like them to go at the moment. But the idea is for them to progress. And depending on the center, you might have you might have exercise equipment like treadmills, you might have rowers, you might have ellipticals, stationary bikes. You get people on and you put them at a certain intensity just to get them working for, and it can be for anything for 20 minutes up to 30 minutes to increase their heart rate, get them working, get a sweat going. You might have a small component of resistance exercise, again, within air quotes, where you have like little plastic, pink weights or resistance bands. But when you think about it, for people who may never have exercised through, may never have done any, let's say, classic form of exercise throughout their entire life, this is the first time exercising. So you do need to go in quite gently. But the whole idea is to build up that exercise capacity over time, over the 4 or 6 or 8 weeks that somebody's in there, to get them to a point where whenever they're performing physical activity, they're not having any turns, they're not having major dips in blood pressure, that they're capable of doing this. And hopefully they're capable of going on to phase 4 cardiac rehab. And phase 4 is considered lifetime community care. And that's where somebody is exercising, hopefully, for the rest of their life. And that's where my research comes in, because we want to work on improving phase 4 at the moment. And I've been talking for a long time, so I'll stop and hopefully we can direct this conversation a little bit better as well.
Yeah, no, that's perfect. And the phase 3, when I was a final year physio student, one of my placements involved a phase 3 cardiac rehab program. And like you say, if you were to walk in off the street as a personal trainer, at the time I was, big into my weight training. I was coaching clients who can squat 140 kilos, etc. And you're coming into this and you're seeing the pink dumbbells and you're seeing the arms flailing. But the important thing is that, and this is what I say to any client, regardless of their state of health, all we're trying to do with exercise is to make some sort of change to your physiology. And if we're trying to, let's say, improve cardiorespiratory function, what we want is that your heart rate is getting up to a certain level and you're able to maintain it for a certain amount of time. And whether that is you on a road bike, pushing yourself hard around the Ring of Kerry, or whether it's an elderly person doing a brisk walk on a flat surface, the cardiorespiratory events there could be the exact same because they're at a different level of function. So that's something that's really important when trying to understand exercise, particularly in the presence of illness. But I think for any personal trainer, understanding exercise at that fundamental level is really helpful. And it's the same when it comes to the resistance training considerations. The pink dumbbell for an 80-year-old post-MI, it could be the same relative intensity as, a 30 or 40 kilo dumbbell for you or I. So it's really important to appreciate that. And that's why we use things like, even in conventional personal training practice, things like RPE or things like percentage of 1 rep max. We're not just giving straight out recommendations as to what weights you should lift. We're saying we want that the weight should be prescribed in accordance with your current capacity. And for people at a much lower capacity, of course, that weight is going to be lower. And there is resistance to the inclusion of resistance training. And I experienced that during that time that I spent in a cardiac rehab program, where when we began to introduce, because we needed to make a change to the cardiac rehab program to make it better during the time that we were there. It was the goal of our placement. And naturally I was like, yeah, lifting time, let's go. So, we did some more conventional barbell work, again, very low intensities, like a kettlebell deadlift, that type of thing. We did it at low intensities, but even at that, some people were quite hesitant to do it. Some people loved it. After a few weeks, they were happy out doing it. Again, at phase 3, we're talking a couple of months past the event, really. And most of the people had been enrolled in the program for a while. And we actually got some feedback from higher up saying that this was maybe too much, that people shouldn't be lifting weights, etc. And we basically solved that by providing evidence showing here are the recommendations, here's the guidelines, etc. So that's just an anecdote from the real world to show that I suppose there is still resistance there. And the idea of bringing in resistance training is something that people struggle with. So what's your perspective on that, Richie, in terms of the utility of resistance training, in terms of its benefit, but I suppose more importantly, as an entry point, the safety of resistance training for someone who's had some form of cardiac event?
Yeah, so I think I'll give a couple of examples here. So when I started setting up the research for this group, obviously we contacted a lot of cardiac rehab centers. The one that we finally decided to go with is it's Liverpool Heart and Chest Hospital. They've got a center for a region known as Knowsley here in Liverpool, and I had a meeting with the entire community team that do all of the cardiac rehab work throughout all of their centers. And so we were having the meeting, and I was explaining what we were doing with it, and that we were going to be focusing on resistance exercise. And I obviously had some buy-in from some of the members of the team, but there were some individuals who their first question was, is this going to be okay? And are you saying that people are not going to be doing any of the aerobic exercises? Because, like we've just said, it's very, very much cardiac rehab is very much aerobically focus on aerobic exercise. And they were a little bit concerned that we were kind of taking the importance away from the aerobic exercise and moving it on to the resistance exercise. And obviously I had to explain to them this, it's just literally for this trial, because we want to see the isolated benefits of resistance exercise in this group, and that, ideally people would move on to a combined component where they would be doing a combination of aerobic and resistance. But even within that meeting as well, we had people wondering, like, is this going to be okay for them? How will we know? And what I had to do was I had to go and find individuals within that do cardiac rehab and that have, some experience with working in resistance exercise. So there's an organization here in the UK known as the BACPR, which is the British Association of Cardiac Prevention and Rehabilitation. And I found an individual who is within that organization. I'm not going to name names now, but he's considered a little bit of a maverick, because he focuses very, very much on resistance exercise in people. And he told me that basically when it comes to cardiac rehabilitation and resistance exercise, they want to wrap patients in cotton wool. And it kind of goes back to, if we think about 20 or 30 years ago in Ireland, if you mentioned exercise at all regarding somebody who's had a heart condition, people are saying, no, they're not able for it. But, he would continuously go back to the same example of, like, if we talk about intra-abdominal pressure when somebody's doing a squat, for example, and the amount of pressure that somebody generates. And he said, you probably generate more pressure when you sneeze than when you're doing, a loaded squat, which is true, depending on the squat that you're doing. So we got him to help us create our resistance exercise program. The teams felt confident with his backing and with our we showed them some of the research regarding resistance exercise, but you could tell that there was a little bit of discomfort in the idea of moving away from aerobic training exclusively, because this is what people are used to. And it's understandable, because people look at a lot of the outcomes that have been used in dealing with cardiac rehab in the past have all been aerobically based. If we think about things like VO2 max is really commonly used as an indicator of cardiorespiratory fitness. And then, while resistance exercise can have a little benefit for that, compared to aerobic exercise, it doesn't. So people were concerned for moving away. But we want to bring that in and talk about some of the other benefits. And those benefits, in our opinion, are very, very much focused on body composition. And the reason we want to focus on body, by the way, stop me and jump in at any point if I'm talking too much. The reason we want to focus on body composition is because if you look at cardiac populations, you'll see that there's a little bit of an obesity paradox. And by obesity paradox, I mean that in people who have a higher BMI, and very important that we mention this BMI here, people who have a higher BMI tend to have a greater survival rates within cardiac populations compared to people with much lower BMIs. And initially that does seem counterintuitive, because people will assume, oh, if somebody's got a higher BMI, they're going to be, they're probably carrying more adipose tissue. That's probably not good from a heart health perspective. So why are they living a bit longer? And kind of subsequent studies looking at more at muscle mass and fat mass are actually showing that it's potentially these individuals who have a higher BMI also have a higher muscle mass, and that muscle mass may be protective in cardiac conditions. And if we get a little bit more specific, we can see that individuals who seem to have the lowest amount of muscle mass and the lowest amount of body fat as well, which, you know, like straight off the bat, you're going to say frail individuals seem to have the highest mortality rates within cardiac populations. And those individuals who have the highest levels of muscle mass combined with lower levels of body fat in cardiac populations seem to do a little bit better. So there seems to be potentially a protective effect of muscle. So what we wanted to see is that there's been no research in cardiac rehab looking specifically at increasing muscle to see what benefits that might have. And we want to see, can it have any benefits on some cardiometabolic risk markers? So things like blood lipids, glycemic control, blood pressure. So that's what we're doing in our research to see, does resistance exercise help from that angle? Because it is something that we need to know. And that's not us saying that it's going to be better than doing aerobic exercise. And like, you know, even now I will say that, you know, a combination of both. And I think you'll agree, a combination of resistance exercise and aerobic based exercise is going to be optimal from a health perspective. So that's what we're doing at the moment.
Yeah. And I mean, I suppose the interesting thing is that, like, someone might say, well, yeah, fine, resistance training helps with muscle mass, or it helps with X, Y, and Z. That's, I suppose, specific to body composition, specific to weight training. But what about the heart itself? And you do see that in in trials where there have been combinations of aerobic and resistance training, that even in some cardiac specific parameters like left ventricle function, for example, which is a fairly important marker of how well your heart is functioning, like it's improved to a greater extent in interventions that do include resistance training. So even at the level of the heart itself, rather than just these broader things like muscle mass, function, etc., there are still very important adaptations. So I always like to bring it back to that, because I don't like, it's one of the reasons I often try to avoid using the term cardio, because it makes it sound like aerobic training is for the heart and resistance training is for the muscle, which is really just not the case. Resistance training has incredible cardiac benefits as well. So yeah, resistance training, it's something that I suppose many people would be maybe a bit more foreign to as well, which makes it a bit difficult. In that, I think if someone is doing aerobic training, maybe it's a brisk walk or a cycle, at some point in their life, everyone has done that. You know, everyone has done some form of aerobic training. But I suppose if you're in your 70s after a cardiac event and now you're trying to learn maybe resistance training movements, that might seem like, oh, that's just for young people as well. Have you found, you know, that type of resistance where people are just, is it just the safety factor, or is it the new activities or getting to gyms? Are they barriers as well?
Yeah, so it's definitely, there's a combination of factors involved there. So another reason that we chose the cardiac rehab center that we are working with now is because they do their cardiac rehab or their community cardiac rehab based out of a couple of community centers that have very, very well equipped gyms in the Liverpool region. Not every cardiac rehab center has that. Some of them are hospital based, and in the hospital based centers, you've got, you know, a few treadmills, a few bikes, and that's pretty much it. It's very, very much aerobically focused. But we wanted to have the option of like giving people a real, you know, full body workout in the gym with, you know, some easy to use equipment. And we had individuals who were like, they said to me, I've never done anything like resistance exercise before, but they said, I'm willing to give it a try for this, because the thing with, you know, having a heart condition or a heart attack or a heart scare is it's a scare, and it kind of gets people to initiate change. And I have found some individuals who are very, very much interested in taking that change on. Now, our trial is open label. So it's not randomized. So we're taking on people and asking them, which group would you want to go in? Because you will still find, even within that, people who've had a scare. I'll give you one example. I was trying to recruit people a couple of months ago, and I had one guy who I was speaking to face to face, like just one-on-one, and I asked him, would you be interested in doing this? You know, because like you have to have somebody who's interested in the trial. And he said, no, I wouldn't want to do that resistance exercise stuff. And I said, well, would you want to do the our control group, which is basically, you know, just, you know, the standard cardiac rehab, which is you go in and do some exercise a couple of times a week. And he looked at me in the eye and he said, I'm not going to lie to you, I'm just too fucking lazy. And I said, okay, I really, really appreciate the honesty. So you have individuals who just, they don't want to make a change at all. And like, you know, that's understandable. But with the people who were, you know, hearing my spiel on what we were doing, they were like, okay, I really want to do that resistance exercise stuff, you know, sign me up. But I've never done it before. And they had questions about, is there going to be somebody there to keep an eye on me? Is there going to be somebody to teach me how to use these machines? And luckily, we've got a really, really good team based out of these gyms where they've got people who've trained in cardiac rehab, and they were willing to help us. They were willing to train people and do inductions, and they're there when people need them to answer questions as well. So it's not been super easy for people because most of the people are coming in very, very naive to resistance exercise. Naive too, but also curious and excited about giving it a try. So that's been really, really good as well. Obviously we've got mixed results. I've you know, I've had conversations during the week, so I call up participants to see how they're doing. And I had one lady saying, she said, I feel like it's starting to lose the novelty a little bit, but she said, I'll keep going for the trial. And I'm like, thank you, I really, really appreciate that. So yeah, you get mixed reactions.
And do we know longer term then, as you transition from phase 3 to phase 4, like what does that look like at the moment in terms of, I suppose, one, the provision or guidance related to phase 4 in the community, and then 2, the continuation or dropout rates? What's that like at the moment?
So I won't give you any numbers on dropout rates because I don't have them to hand right now. But I will say, again, like cardiac rehab itself, phase 4 cardiac rehab is hugely varied, and it very, very much depends on what is there for them in the community. So like I said, our center is based out of Knowsley in Liverpool. I think they've got a very, very good system going. So they've got a program which is called Activity for Life. And this is your phase 4 program. So people come into Activity for Life. They can sign up to it for as long as they like. And they get a slight discount. And it comes in 2 forms. So one is where they can come to cardiac rehab classes that are held at the gyms, group classes. And these can be, you know, circuit training. They can be like spinning, things like that. And people will usually come about twice a week. Or they can pay for like an additional fee. They can pay for full access to the gyms, and they can come into the gym whenever they like to do whatever they want. But that's not particularly structured. And that's kind of how we're taking people on, because we give them the structure within that that phase 4, and we tell them, okay, we want you exercising 3 days a week. We want you doing these exercises, etc. But for most people, it can vary hugely as to what it is. I think 2 days a week is quite common for people to come in, and it's very, very much class based. But then you've also got a lot of telehealth interventions have come online now, where people can do these things online, and they can take part in a class, you know, via Zoom or something like that, if somebody has the technical know-how to do that, which is really, really useful for people who may be living in the countryside and don't have access to these services that might only be available in larger urban areas. So again, it varies hugely as to what people can do. But we want to offer more structure to it, and that's what our intervention is kind of trying to do at the moment.
Perfect. And tell me, what for your intervention at the moment, then I think it's good for people to maybe get a feel for what we actually mean when we say resistance training. Like, can you give an example of what a training week might look like for someone?
Yeah, absolutely. So we wanted to keep it as simple as possible, because like I said, a lot of people were naive to resistance training, never done it before. So we thought, okay, what can we do to keep this as simple for people as possible? So first, if we start with the exercises, we decided to not use any free weight exercises, or at least any complex compound free weight exercises. So for example, instead of doing a free weight squat, we'll use a Smith machine squat. I know, God forbid. Again, instead of doing a free weight deadlift, we used deadlifts within the Smith machine again. Things like leg press, chest press machine, shoulder press machine. And what we wanted to do was make every exercise session a full body workout. So there will be a legs component, and there will be an upper body component as well. And that upper body component will include a push and pull movement. And then the legs movement will include a kind of a hip dominant movement and a quad dominant movement. Okay, so we want to get as much of the musculature involved as possible. So all of our exercise sessions are composed of 6 exercises. And then we have an A-B style program. So basically you've only got 2 different sets of exercises that people alternate every week. And we have people doing 3 sessions in the gym a week. So maybe A, B, A, B, A, B, A, B. And the reason for that, again, is to keep things as simple as possible for people who have never done this before. And when they go into their session, they pick up a little piece of paper and they just fill in their details as they go along. So for example, the weight that they're using, the amount of reps that they do on each set, and the amount of sets that they perform. And for this, again, to keep it simple, we said we'll start off for the first week with just doing 2 sets of 8 to 12. And then we said, once you do that, next week, move up to 3 sets. And then the following week, move up to 4, and then stick with 4 sets all the way through. And we explained how the progression is going to work to them as well. And we said, so once you can do a certain weight for 12 reps for all 4 of your sets, increase the weight. And we have to reassure them then the amount of reps that you're going to be able to perform, it's going to drop. But that's okay. You'll build up over time. And eventually, once you're feeling stronger and you're capable of doing all 12 reps, we increase the weight again. So there's very, very much a focus on progression within the weights, because we want to challenge people as much as possible to see if we can stimulate that muscle growth. I don't know if that's enough of an explanation.
No, that's perfect. And then just as you get out of that kind of, formal gym setting, and people are, obviously this is different to your intervention, but when people get to the home environment, then at the moment in that system, for example, in Liverpool, as they get to phase 4 and they're more so working in the community, are there programs that people are given to take to the gym themselves? Are there home programs? What does that look like?
For standard cardiac rehab?
Yeah, just as a very general question, like, do you know what kind of systems work like in terms of when someone's done with the formal program itself?
So in terms of phase 4, it's all group classes. In terms of if somebody doesn't want to go to a gym and they want to do it at home, I don't know what they actually receive. But if you can kind of imagine what we were talking about earlier regarding kind of the low intensity of cardiac rehab, a lot of people will be given programs, something similar to that. So it's programs that are just designed to get them moving various parts of the body, elevating their heart rate for a minimum amount of time to help them through the classes. Not everybody does that. And like, there are some people who take the initiative to go a little bit harder and kind of do their own thing. So some people will actually buy equipment. Some people will use rowers at home, for example. Some people will use ellipticals at home, but it varies enormously. And again, this is one of the major issues with cardiac rehab is it is not standardized, and it is based very, very much on what each center wants to provide to its members.
Yeah, and that's kind of what I'm getting at, is that there seems to be like huge variation in terms of what it looks like out the other end for people. And even I suppose on the inclusion side as well, like if you look at different countries, I've read some kind of reviews on like what's accessible in different European countries at least, and it seems like even like the type of condition that you have initially, it varies by inclusion criteria in particular countries, but then the types of facilities are obviously massively variable then. And even like, are the services publicly or privately funded, etc. To my knowledge, I presume it's the same in the UK. Ireland and the UK, it's cardiac rehab programs will be mostly publicly funded at the moment, as in by virtue of being an inpatient, people are referred to the programs. Is that right?
Exactly, yeah.
And are there any private companies that run cardiac rehab? Do you know?
So the individual who I was telling you about earlier, who did our cardiac rehab resistance programming, the Maverick, he does private, but it's not exactly it's not company based. So there are some individuals who do it privately, but they're obviously certified through the BACPR to do so.
Okay. Yeah, because what I've been thinking is that, I suppose with so many people having events, and not even just events, but even having something like, well, you might call it an event, but like stable angina, for example. Someone gets exercise related symptoms in their heart. They might get intermittent claudication in the legs. Like they're at the point where they have symptoms of cardiovascular disease. Like that's a very large proportion of the population. There's huge amounts of people that could benefit from intervention, but having just publicly funded programs and those types of facilities are probably not that realistic in the HSE to the extent that you might want it. So what I'm always thinking is, like, it's just a problem at the moment because of the lack of standardization. But I think like the role of personal trainers and strength conditioning professionals longer term, the ideal from my perspective would be from that kind of phase 4 and beyond in the community, that those individuals would have some sort of network. Like, let's say you're certified to provide cardiac rehab, you have a gym, and it's maybe a specific small group class, or you work with individuals who are on that cardiac rehab spectrum. Like, that's my kind of idealistic vision of the future of personal training. But do you have a similar vision? What do you think the personal trainers could in the future play a role here?
Yeah, so we had a conversation of this with with our research team last week, and somebody asked how many people that are referred to cardiac rehab are referred based on potential risk or being at elevated risk, because technically that is what cardiac rehab is about. It's about you get referred by having an event or being at elevated risk, but in reality, there are very, very few individuals that are at elevated risk that are referred. It's almost everybody has had some sort of an event. And I think we are very, very much missing a trick here. Like, and yourself, myself, and everybody else will know prevention is better than cure. So we want to be talking about like getting people involved in exercise, and healthy eating, obviously, throughout their life, as opposed to, you're at a point now where, like, you could be at risk of having an event. It's I don't want to say it's gone too far at that point, but it's harder to deal with. But I do think that there is potential for referring on these individuals who have a high risk, to get them into some sort of a program where they can start taking care of exercise and potentially, hopefully, reducing their risk. And then, that is the whole primary prevention, as opposed to the secondary prevention that the BACPR deals with at the moment, despite the fact that they have prevention written in their in their name and their title. It's really important. The thing I will say about it is, in cardiac rehab, like I mentioned, you have a lot of buy-in for people because they've had an event.
Yeah.
Whereas in a population that is otherwise healthy and they've been told that you've got these markers for a certain condition, and you're at a higher risk of something, it doesn't incite a lot of buy-in from them, which is a terrible thing to say. I'd like to give another example of it. I'm working with another group here in Liverpool. We're doing some research in NAFLD, so non-alcoholic fatty liver disease. And they did a little bit of research prior to me starting with them. And it was about, they offered a lifestyle intervention to individuals who had early stage NAFLD. And like, as you know yourself, with NAFLD, the only way it can be diagnosed is like by a combination of liver markers, and then you can do things like MRI, or you can there's a couple of other functional tests that you can do to check liver fibrosis, and they will have no other markers. Now these people will probably not be in the healthiest of condition. They're probably potentially a little bit overweight. They might be suffering from slight dyslipidemia. They might have slight issues with glucose tolerance, but they're not so much the stage where they need to be medicated for any of these. They probably don't exercise a huge amount. But if you tell them that, oh yeah, you've got NAFLD, which is not a very, very well-known condition anyway, and you're at a little bit of risk of something which is as serious as like liver cirrhosis or steatosis or something like that. Out of this population of, I think it was 150 people who were offered this lifestyle intervention, 10% decided to take it up. And this was a free intervention. We're saying, we're going to provide you with exercise, we're going to provide you with dietary guidance. Would you like to get on board? 10% of people said, like 15 people said, yeah, we'd like to do that, because they don't consider it serious enough. because it's just at risk. They haven't had some sort of an event. And the same thing happens in cardiac rehab. So if you're trying to encourage people to exercise and eat well because they're at risk, I think if they haven't been focused on that up until now, and they haven't had an acute event like an MI, God forbid, it doesn't seem to be enough to motivate them to make those changes. I don't know if you have anything to say to that, but I think it's relatively common in medical care.
Yeah, I think unfortunately, like that conceptualization that we have of longer term risk it's not something that weighs heavily on our psychology. Like it's so abstract, particularly if you're talking about like NAFLs there. Like you're telling me I have fatty deposition in my liver and that's going to increase my risk. Like even that, like that's very abstract to people. Even things that are maybe more familiar to people would be my blood pressure is high, my cholesterol is high, I have diabetes or I have pre-diabetes, etc. Even at that, still getting people to adopt exercise interventions and dietary changes incredibly difficult, because again, most often people are asymptomatic. And I see this even in people, in their 20s who are into fitness. They'll have an elevated, maybe a slight elevation in their blood pressure, or they'll have an elevation in their LDL, for example, and they'll say, sure, it's fine. I have everything else. Well, everything else is good. Sure, I'll be fine. But you've got atherosclerosis there that's brewing for the next few decades that will eventually catch up with you. But because it's so distant, because it's so abstract, because there hasn't been that inciting event, it's incredibly difficult to get people to, take it up, as you said. So I suppose the ideal, if we could control everyone, would be that everyone is on an exercise program from when they're a child and everyone has perfect nutrition. But sure, that's not realistic at all. That's just not the way things work. So yes, prevention is better than cure, but I do understand why secondary prevention is currently the main focus of cardiac rehab programs, because, well, you're going to get better uptake. And of course, it is the highest yield in terms of, preventing an event that's going to be coming very soon. But long term, you want to catch the disease processes very early on, particularly with atherosclerotic cardiovascular disease. And if everything could be an ideal world, that'd be great, but it's not, unfortunately.
Yeah, you can't control people yet.
Yeah, yet. Wait until we have a health dictatorship.
Bring it on.
But is there anything else that you feel that is important for people to be aware of? I'm assuming that personal trainers are listening to this podcast. Maybe people have sent it to family members who've maybe had an event, or they're at elevated risk, etc. Anything else that you'd like to add on the cardiac rehab front?
Yeah, so it's one thing we haven't kind of spoken about is quality of life, and I think that's a huge aspect that we need to kind of to talk about with exercise. So a lot of people don't realize that, some people's aversion to exercise is because they're physically not very capable of performing it. And that can often be due to skeletal muscle deficiencies. They just don't have the musculature to allow them to do that. But helping to build on that allows people to move more easily. And with the intervention that we're doing at the moment, so we do a quality of life survey at the end of it as well. Just ask people how different aspects of their life have been affected, and then we do some qualitative work on the end of it as well, where we ask them, how has life been different while you've been doing that? And from our resistance exercise group, the changes have been really, really impressive. Like, people just talk about how life is a little bit easier for them, and like it can be things as simple as carrying the groceries for me. It's like so just to give an example, we supply our participants with ready-made drinks of protein, so like protein shakes in bottles, and they come in like slabs of protein, and they're pretty heavy, and one of the ladies who was working with us, she came in for her end visit, and she told us that she was bringing out a couple of slabs to her car, and she said that she had no trouble doing it, and she said previously she wouldn't have even attempted to do it before, and that was because like she'd been doing the resistance exercise for so long. She felt more comfortable doing things, she felt more confident doing things, and she felt she was genuinely physically more capable of doing these physical activities. She said she feels it's like, some of them said it's improved their posture. It's improved how they feel about their bodies and how they look in clothes. Like another lady came up and said she bought a top that showed off her shoulders for the first time ever. And she said she never did that because she always hated her arms. And she said she liked it now because she had arms to show off. Brilliant. Which I thought was like, that's not something that you're going to put down as a primary endpoint for a research study. But that's a nice endpoint for some people to say, I feel more confident in clothes. You know, I had another participant, and they weren't supposed to do this, but they decided to send me along some photographs from of their legs basically flexing, and it's like, didn't have muscles there before, and I was like, all right, fair play to you, mate. Good
nice.
Yeah. So like those improvements in quality of life are huge as well, because we're talking about an older population, and quality of life is everything. You know, like what good is it if we say, okay, you know, your left ventricular function is better now, or your flow mediated dilation is better, or your cholesterol is better, if somebody, you know, can't get out of bed in the morning, or can't go down to play with their kids, or do the groceries. But we're seeing improvements in life. People are feeling happier with this program, and that for me is huge as well. And I think that's another, like, you know yourself, like resistance exercise helps with these things. It helps with confidence. It helps with our ability to tackle life. It makes life a little bit easier. And if we can do this for a population where life is suddenly harder because of a cardiac event, that's hugely important as well.
100%. And I think, you know, as much as it's kind of funny to laugh at the idea of, oh, I can show off my arms now, it is a really important point, because what we talked about a minute ago was the idea of things like cholesterol and blood pressure being so abstract, but how you feel in clothes is very, very real and in your mind every day. Like that's something it's very close to home. And very often as personal trainers, or, you know, people who are into the science of health and fitness, we get to a point where we kind of forget what it was like to first start exercising. We forget what kept us going in those first 12 months, let's say. And we'll say things like, oh, it's not about how you look, it's about your long-term health, etc. But none of us thought that on our first day in the gym. Like most of us, we started the gym and we were like, yeah, I want to get arms, you know, I want to grow my arms, or I want to, you know, be able to see my abs, or whatever it happens to be. Like a lot of people, a lot of personal trainers, even the evidence-based people we all try to be on our high horse, a lot of us got in out of a position of vanity to some extent. Like you wanted to look better in the gym. That's totally fine. And you have to remember that when people, even in a clinical population, people get into the gym, they feel a bit better in their clothes, they feel a bit more confident. That's not something that's a primary outcome, but it's really actually quite powerful from an adherence perspective, because you're like, you know what? I actually feel good. I might come back again. I might keep doing that. And you begin to accumulate these health benefits as a byproduct. And over time, as it's integrated into your life, maybe now you focus more on those health outcomes, and it's just so normal for you now. But the initial kind of potentiating factors might be a bit shallow, if you will. You know, I feel good, I look good. You know, that's what matters to me in the moment. And that's fine. I like to remind people that is totally fine, because I even have clients sometimes that will shy away from telling me certain things like, I know this sounds like really shallow, but I put on a shirt the other day and I felt great. It looked so good. That's totally fine. Like you can admit that, you can be okay with that. All of us have been there.
Yeah, absolutely. Like, you know, people say it's shallow. I don't know how much, like, you know, it's a powerful motivator.
I agree.
And it works. And like, you know, especially if, you know, somebody who's in their 60s is saying that to me, I'm like, brilliant.
So what you're saying is the way we get better buy-in in cardiac rehab is like, we get a picture of 65-year-old lady with her like vest, she's gardening and she's flexing. That's the way.
Have you seen some of the other, like, you know, common photographs that are used for talking about resistance exercise in older people? Like this. I did an article for it's a website called The Conversation, and they just talk about like recent research and stuff like that. And I remember the picture that they used, and it was just like a bunch of like really much older people in the gym, and they were like lifting these little resistance bands, and it just like that's not what people want to see. They want to see people doing like really, really badass stuff, like, like
Yeah.
doing a bench press or something like that, or like, squatting. And like, there are pictures of that of women around. Why
Yeah.
aren't they more common? Like, that's what people want to see, and that is motivating. Whereas if you see a bunch of people in like a group circuit class, it's like, that's not particularly encouraging to me.
Yeah, and it's always the oldest people that they choose as well. It's like the lightest of weights. Yeah, we reject TheraBand culture around here, so let's get rid of that. Anyway, I think that's probably most of what we wanted to cover in terms of cardiac rehab. Like, obviously, this isn't supposed to be a clinical podcast where you're going away and now applying this with patients. Instead, what we want you to get out of this is the idea that if you've got a family member, or maybe it's yourself, and you've got hypertension, or you've been told you're at elevated cardiovascular risk, or you've had a previous event, that resistance training and exercise generally, as I suppose the first point, is both safe and effective. There are programs available. Maybe you weren't given any information about them. Have a look, speak to your GP, speak to maybe your physio or your cardiologist or whoever it is you're in contact with, see what's accessible to you. And I think that, yeah, you'll probably be better for it.
Absolutely. And one thing on that is, like, for any, PTs listening to this, and if this kind of is an area that you think you would like to get involved in, it is something you can get involved in. I'm not sure the name of the governing body in Ireland, but for example, if you're in the UK, like the BACPR, you can get in touch with them. You can find out about certifications that they run, so that you can get certified to help provide this kind of care for people. So like, you can offer classes for people who've had some sort of a cardiac condition.
Yeah, I think it's the IACR. I can't remember now, but I'm pretty sure it's something like that. Yeah, I don't have it in front of me, but I'm pretty sure there's an IACR that publish guidelines. I think for Ireland, they do audits and things like that. But anyway, there's plenty of information available out there. And, like that, maybe you just want to learn more about this topic, or you're providing information to a family member or just for yourself. There's so many, published pieces online in terms of guidelines and reviews of cardiac rehab, and the different, more information on the different phases and the centers near you, etc. So it's all out there.
Absolutely.
So finally, before we finish up, Richie, we're talking about resistance training. What are your training goals? What do you do in the gym? Are you like a powerlifter, bodybuilder dude, or what's your story?
That, lad, you just need to look at me to tell you that that's not the case.
I think the delts are looking good in that My Protein t-shirt.
That's why I wore this t-shirt. Yeah. It's a very flattering t-shirt. I, at the moment, lad, it actually feels like I am just exercising to not die.
That's fine too.
So like, the last few months have been fairly stressful, and I've actually noticed that the last few weeks in the gym, I have been falling apart. I'm like riddled with exercises. With injuries, I should say. I'm riddled with injuries. I've got a shoulder issue now. I've got some issues with my knees. And I just think I really need to bring a deload on just to take a break. But like, in terms of goals at the moment, I'm exercising to stay as healthy as I possibly can. Like, obviously, I'm exercising to maintain as much muscle as I can going into, as I get older. I don't think I'm going to be building a huge amount more from now on, but I'm going to be maintaining as much as I can to stay functional. And one thing I want to do is I want to get more into aerobic exercise, because it's something I don't do a lot, and that's just out of time and habit. And I need to do it a little bit more, because, again, heart health, prevention, all that.
Yeah, absolutely. And I suppose that just solidifies what we discussed earlier. It's not either or. It's not about being the resistance training person that's anti-cardio. It's not about being the cardio person that's anti-lifting. It's both, and both seem to have independent and synergistic benefits when it comes to cardiovascular health. So get on it. And it's always nice to see people who walk the walk in terms of their research, so obviously you apply that in your own life as well. One final point, just not to prolong it too much, but just because it was mentioned, what is a Mediterranean diet? People might be wondering, what's that?
Good question. So what we use is a Mediterranean style diet. Mediterranean diet is classically the diet of the Mediterranean region, which is high. If you look at the main component of it, it's going to be higher in fruit and vegetables, higher in olive oil, very, very specifically, extra virgin olive oil. And then it will usually be relatively high in legumes, so beans, peas, lentils, whole grains, seafood, with comparatively lower amounts of red meat compared to Western Europe or Northern Europe. And what else is there? A very, very moderate consumption of red wine, again, depending on the region. There's no one single Mediterranean diet. And to be honest, I don't like the term Mediterranean diet because it makes people think on something very, very specific. I think Mediterranean style diet helps us encompass a lot more about what it is, because you can have, and you will see research on an Indian Mediterranean style diet. So they've done this research in India and they've just modified the diet to be more similar to how people eat over there. I've seen Korean Mediterranean style diets. And it's all just like focusing on the individual components as opposed to focusing on what's a Mediterranean diet. Is it pizza and pasta or whatever? And like our research is a northwest Mediterranean style diet. So like we have like one of the big dishes here in Liverpool is a thing called scouse, which is basically like kind of like Irish stew. And we've given people recipes. I've modified it, so I've made it higher in monounsaturated fats, lower in saturated fats. I've added some legumes to it, more fiber, more vegetables. So you can modify things to be more Mediterranean style. Yeah,
that's cool. So it's some sort of diet. It's a dietary pattern fundamentally that
exactly
exhibits certain features, and that's generally good for cardiometabolic health, I assume.
Exactly.
Assume that's the result of your research.
Well, that's what we're hoping. Let me analyze the results in a few months' time.
Yeah. So anyway, I just said I touched on it because it was mentioned as part of the intervention. So you're saying that carnivore type of diet wouldn't be optimal, would it? Or you'd be
potentially not, considering like one of the main things we like to reduce is LDL, and on carnivore diets people seem to love increasing their LDL as much as possible because apparently according to some people it's beneficial. It's not.
Yes, sarcasm implied. Right. Anyway, that's the end of this episode. Thanks very much for listening, guys. Richie, do you have places that people can find you online, on the socials, or maybe your ResearchGate or wherever?
Yeah, sure. I'm on, I suppose, most active on Instagram, and you can find me at Be More Nutrition. And I'm on Twitter, just Richie Kirwan, and I'm on ResearchGate as well as Richie Kirwan. Basically, if you go to my Instagram, I'll probably have links to all of my other socials there as well. So just check them out.
Brilliant. So give Richie a follow. And as always, guys, you know where you can find us at Triage Method on Instagram. Find all of our services, etc. there. And we'll see you in the next episode. Thank you very much, Richie.